And I think without further ado, we're going to ask Eugene to present our next speaker. And it's a great privilege to be able to have her on this AGM as well.
Thank you, Jan. So we would like to welcome Dr. M Cretella. Dr. Cretella is the past executive director of the American College of Pediatricians, and currently she co-chairs the organization's Sexuality Council. Dr. Cretella was elected to the American College of Pediatricians Board of Directors in 2005 and served 2 terms as president prior to being hired as the executive director. Dr. Cretella previously chaired several committees, becoming one of the American College of Pediatricians' chief researchers, editors, and spokespersons. Following publications of her article, Gender Dysphoria in Children and Suppression of Debate in 2016 in the Journal of American Physicians and Surgeons, she was interviewed by Tucker Carlson and became one of the world's most outspoken physician critics of gender ideology. Dr. Cretella has been consulted by multiple media outlets and serves on the advisory board of Advocates Protecting Children, the Alliance for Therapeutic Choice, and is a spokesperson for the Catholic Medical Association on Gender and Sexuality. She is a peer reviewer for the journal called Issues in Law and Medicine and for the Journal of American Physicians and Surgeons. Dr. Cretella received a medical degree in 1994 from the University of Connecticut School of Medicine. She completed a residency in pediatrics in 1997 at the Connecticut Children's Medical Center in Hartford, Connecticut. She completed a fellowship in college health through the University of Virginia in 1999. After 12 years of group practice in rural Connecticut and Rhode Island, she left clinical practice to devote more time to family and child advocacy. Dr. Cretella and her husband are the proud parents of 4 young adults. Dr. Cretella, welcome.
Thank you. It's a pleasure. It's an honor for me to be here. It's an honor to be here. I want to discuss transgender belief in young people and how we, especially as Christian physicians, can lead the way in healing minds, embracing bodies, and saving both lives and souls. And this came out right about the same time as 2 quotes from 2 very prominent gender ideology promoting physicians in America. Diane Ehrensaft is a psychologist, a child psychologist who has really led the way in promoting the chemical and surgical assault on children. And she's affiliated with the University of California in San Francisco and literally teaches parents, educators, medical students, and physicians that, quote, "We cannot know someone's sex unless they tell us. Some boys have vaginas and some girls have penises." Even more striking is a statement that came out from Dr. Deanna Adkins, who heads the gender clinic at Duke University for children, the gender clinic for children at Duke University. She is an academic and clinical pediatrician, and she was quoted in a journal article as saying, "It is counter to medical science to use chromosomes, hormones, internal reproductive organs, external genitalia, or secondary sex characteristics to override gender identity for the purposes of classifying someone as male or female." Now let that sink in. I mean, chromosomes, hormones, genetics, organs, that's the physical material world. That is science. And yet she is saying that what a person perceives, this essence of maleness, an essence of femaleness, trumps physical reality. This is why we can definitively say we are dealing with Gnosticism. That ancient Christian heresy that the spiritual is good, the physical is bad, and the spiritual, or the internal essence, the secret knowledge, the one who knows, has secret knowledge that trumps physical reality, to the point that physical reality is to be overcome and abhorred. So this is the root of the evil. The root of the evil is spiritual, and this is what every Christian needs to understand first and foremost, so that we can evangelize the culture and the truth. So let's go back to the beginning. Let's talk true definitions, because every revolution, every cultural revolution begins by perverting the language. You pervert the language before you can change behavior. So what's the true? What defines sex? Sexual reproduction is defined by reproduction. That's the simple thing to remember. In all the life sciences, sex is defined according to how an organism is structured to function during the reproductive role. If an organism is structured to donate genetic material during the reproductive act, we designate that organism as male. So whether you're speaking about plants or animals or human beings, a donor of genetic material during the reproductive act is male. The recipient of that genetic material during the reproductive act is female. That is universal when looking at how do we define sexual reproduction. So, many trans activists, both within medicine and without, will claim that intersex people prove sex is not binary, but a spectrum. And again, we have to enlighten or bring our colleagues back to basic principles. There are not intersex people. There are people with intersex conditions. And these conditions are actually called disorders of sex development. Disorders of sex development are not new sexes, because they are actually malformations of the binary male or female reproductive system. Disorders of sex development, DSD, do not produce new sexual organs, new reproductive organs, new sex cells. There are still either sperm or egg. Sex is binary. DSD are rare congenital disorders, fortunately. They fall into two categories. Some DSD cause ambiguous genitalia, which are apparent at birth. Other forms of DSD, the babies are born with non-ambiguous genitalia, but later in life are found to have a genotype that does not match their phenotype. One example of a DSD that causes ambiguous genitalia is congenital adrenal hyperplasia. An example of a DSD that causes a mismatch between genotype and phenotype is complete androgen insensitivity syndrome. It used to be referred to as testicular feminization, but more accurately, it is androgen insensitivity syndrome. There are complete and incomplete forms. Again, because these individuals have malformed reproductive systems, and each type of DSD is associated with impaired fertility, we can definitively say these are properly called disorders and not evidence of new functioning sexes.
Dr. Cretella, I'm sorry to
Yes.
interrupt you again. We are still on the trans activist claim slide.
That is correct. I'm talking about intersex and DSD.
Sorry. My
Yes.
apologies. Sorry.
No worries. Okay. So they are rare. They affect, fortunately, only 0.02% of the population. Occasionally, we may hear the term transsexual versus transgender. Transgender, it's important, I think, for us to look at how the Diagnostic and Statistical Manual, 5th edition of the American Psychiatric Association defines transgender. What's unique is that the APA in the DSM-5 refers to transgender as a broad spectrum of individuals who may transiently or persistently identify with a gender different from that associated with their biological sex. And what I point out is we are always being told by the transgender activists, both in medicine and without, that, oh, your gender identity cannot change. And yet here in their authoritative book, the DSM-5, they admit, oh, sure, your transgender identity, it may be temporary or it may persist. So they want to have it both ways. As far as the term transsexual, transsexual is usually applied only to those who are transgender who have actually taken hormones and undergone one or more surgeries. That term transsexual is falling out of favor. The current narrative, which still exists and is heavily pushed in the United States, but is seeing change, fortunately, in European countries. The current narrative is that some children are born transgender because they are born with a brain that's a different sex from their body. And their gender identity is innate and immutable. That's the number one part of their narrative. Number two, the transgender activists in medicine will tell you that these children are absolutely not mentally ill. Number three, counseling to help these children embrace their bodies. That counseling is universally unethical, harmful, and futile. And the fourth part of the narrative is that trans youth will commit suicide unless you affirm them in their false belief, socially and medically. So we're going to take a look at each of those 4 pillars of the narrative. The first one, what is this? Where is this notion that they have opposite sex brains coming from? And to point this out and demonstrate that it is politics shaping the conversation, I want to compare the transgender brain studies to the brain studies of young people with anorexia nervosa. There are probably hundreds of studies of patients with anorexia nervosa looking at MRIs, functional MRIs of their brains as compared to their non-anorexic peers. There have been high quality studies, they replicate one another, and yet I'm willing to bet that not one physician in the audience has ever been told, see, these brain differences prove that anorexic patients have obese brains trapped in skinny bodies. I mean, that would be ridiculous to even suggest. And yet, among the transgender functional MRI studies, there are very few. They do not replicate one another's findings. They find differences among groups of those who identify as transgender and those who don't. But good quality studies will replicate the same differences, right? That's one of the pillars of good science. You carry out a standardized test and you will replicate one another's results. That has not happened even once among the transgender brain studies. So there are far fewer of these studies, far lesser quality. They've not replicated one another. And yet these junk science studies, this is what doctors and transgender activists point to say, look, here's our proof there are girl brains trapped in boys' bodies or boy brains trapped in girl bodies. Complete science fiction. And let's take this, explain it one step further. We don't need brain studies to tell us that no baby is born with the wrong brain. We know from genetics, from the moment of fertilization, every cell, every nucleated cell of a person's body, every nucleated cell in every single organ has the same sex chromosomes. We also know from genetic studies that between males and females, there are at least 6,500 shared genes that are expressed differently between males and females. So male brain tissue is genetically different from female brain tissue by virtue of the genes on the sex chromosomes alone. Furthermore, in utero, by 8 weeks gestation, male infant brains are further masculinized by endogenous testosterone, which is secreted from their testes, again, beginning at 8 weeks gestation. Female infants do not have male genes. Female infants do not have male testes. Therefore, no child is ever born with the wrong brain. It's complete science fiction. So then we could be asked, well, even though those transgender brain studies don't replicate one another, what if one day they do? And we know, and there are differences. What's going on? Well, what's happening is, again, a scientific process that everyone acknowledges is true. Our brains are not sterile. We are not born with a brain at infancy that fails to change. We are born with a brain that is constantly changing and shaped by our own behavior, our own thinking, and more importantly, our relationships. The brain, the neurological wiring of the brain, is first and foremost shaped by mother-infant gaze. And this phenomenon of the changing brain is called neuroplasticity. So if we ever do get studies that replicate specific differences between transgender individuals, identified people, and non-transgender identified people, those differences are more likely going to be due to identifying as transgender. So brain difference is the result of our different behaviors, our different identities. Brain differences do not cause the transgender behavior or identification. How about the claim that gender identity, transgender identity in particular, is innate, inborn, and completely unchangeable? Here again, when we look to genetics, to twin studies, particularly identical twin studies, we can see that no, it is not innate and immutable like sex or skin color. Again, let's take anorexia nervosa. If we look at those twin studies, if one identical twin has anorexia nervosa, the likelihood that another identical twin will have it varies from 44% to 70%. Among transgender twin studies, if one identical twin identifies as transgender, the chance that the other identical twin will also identify as transgender is a low 28%. So what does this mean? It means that genes do not determine either psychological disorder. If genes alone were determinant, then the concordance rates among identical twins should be very close to 100%. What we can see comparing these identical twin studies is that genetic influence does exist for both of these disorders, but the genetic influence of anorexia nervosa is much greater than the genetic influence behind a transgender identity, because 44 to 70% is significantly greater than a mere 28% concordance. That's the science. But I bet no one in the audience has ever been told, oh my gosh, look at that genetic concordance. Anorexia nervosa, it's innate and immutable. We can't treat it. No, we're not told that. But what are we told about transgender? You bigot. You are suggesting that counseling, that there could be mental illness behind a transgender identity. You're suggesting that we could counsel them to actually embrace the reality and goodness of their bodies? You bigot. That's innate and inborn. So I just want you to understand the true science is being shaped and manipulated. Well, it's being hidden. But then when it is brought forth, it's being hidden, it's being manipulated to suit an agenda. Basic behavioral genetics, genes do not determine any behavior. We are not hardwired like a machine to think, feel, or behave in a particular way. It's a combination of our vulnerability. Yes, we're made of DNA, so DNA has something to do with it. But it's a combination of our vulnerabilities, personality traits, number one. Number two, our environment. And number three, our agency, our free will choices. And that can involve anything and everything from how much time, particularly when we're looking at young people, are they binging on the internet? And young people today, are they addicted to pornography? Do they have, are they pursuing a particular religion? So free will choices, environmental factors, and our biology combine to shape who we are. That's basic common sense. It's basic behavioral genetics as well. The American Academy of Pediatrics continues to embrace the false narrative previously discussed, insisting that some kids are born with brains that are opposite their bodies. And in their 2018 policy statement, which they recently reaffirmed, they insist that any child of any age who identifies with a different sex should be affirmed as that different sex. So socially transition, even as young as 18 months. Puberty blockers, Tanner stage 2. Wrong sex hormones as young as age 8. Wrong sex surgeries are being performed in America as young as age 13 for double mastectomies and 17 for penectomies or castration. Truly evil and criminal. Though it's not considered that in the US at this point, my hope and prayer and belief is that it will be soon. In 2018, when the American Academy of Pediatrics released the policy statement, Dr. James Cantor, who previously worked in Dr. Ken Zucker's Toronto gender identity clinic with children, was quite shocked by it. So he actually did a fact check. He pulled the references and fact checked the policy statement. and found that the American Academy of Pediatrics, and this would not be the first time, misrepresented every reference they cited. And that if you actually pull the references they cite, the references promote watchful waiting. They promote the opposite of what the American Academy of Pediatrics claim is in children's best interest. So this is simply to point out that sadly, our American medical organizations, once the American Academy of Pediatrics puts out a policy statement for children and young people, the American Medical Association and many other medical associations in the United States simply hop on board. They don't do their due diligence. They just promote, so the same, in this case, the same political agenda, the same junk science. We are often told, often hear, that social affirmation of a transgender identity in a young child, having them change their name, their pronouns, their clothing, their hairstyle, that's totally safe and reversible. No harm is done. Now, anyone who has, I mean, every mother, grandmother, grandparent, school teacher of young children should realize that is a ridiculous statement to make. Why? Well, you don't lie to children. We don't lie to children because children are gullible, because children believe what they are told, because children have a wild imagination. So, and by the way, prior to 2013, when gender dysphoria was still referred to as gender identity disorder, families were told not to affirm because it was recognized if you encourage role playing as the opposite sex and you play into that, you're going to cause their gender identity disorder, you're going to cause their gender dysphoria to persist. It's common sense. And on this slide, there were two studies by a Dr. Christina Olson, looking at a single data set, claiming that the mental health of trans identified children was better among families who reinforced that trans identity. A Christian sociologist, Dr. Walter Schum, was intrigued by this because when he reviewed it, he spotted missing data. He contacted Dr. Christina Olson and asked her if she would be willing to share her entire data set with him. She did. He reanalyzed her entire data set and, not surprisingly, found the complete opposite conclusion. If you looked at the entire data set rather than cherry picking it, and have accurate statistical analysis, the children who were affirmed as transgender by their families had worse self-esteem, more anxiety, more depression than their peers. And most significantly, the longer they were affirmed in that trans identity, the worse their self-esteem and anxiety became. His results were published in February 2020 in the Lineker Quarterly, which is the medical journal of the Catholic Medical Association. When you take social affirmation, so affirming a child in a false identity, plus suppress their pubertal development, what we're doing is a self-fulfilling prophecy. We're affirming, we're reinforcing their gender dysphoria. And in this case, it's a self-fulfilling prophecy to a very toxic future. There are now 5 studies, the DeVries and Brick are 2 of the 5, but there are now 5 studies to demonstrate that children who are socially affirmed and placed on puberty blockers virtually 100% of them will go on to take a transgender identity and request cross-sex, or as I say, wrong-sex hormones. So this protocol causes children to identify as transgender and to go on. Puberty blockers, as we'll talk about, have their own toxicity, but the cross-sex hormones are even worse. The thing to remember here is that stealing puberty, because that's what we're doing. When you give puberty blockers to a child about to go through normal puberty, we're stealing puberty, and that robs children of the developmental stage during which many will change their minds. And we know this because prior to all the affirmation of transgender identity, the vast majority of children with gender dysphoria embraced their bodies by young adulthood. So stealing puberty with puberty blockers robs gender dysphoric children of the developmental stage during which many will otherwise change their minds. But Dr. Cretella, what about the Endocrine Society guidelines that came out in 2017 saying that this is all good, saying that social affirmation is reversible, saying that puberty blockers are fully reversible? Shouldn't we believe the Endocrine Society? Well, what's fascinating is that when you go to the Endocrine Society guidelines, they have a built-in rating system. They have 22 guidelines that they put forth. 22 guidelines. 20 of those 22 guidelines, which encourage the social and medical affirmation, are based on very low to low scientific evidence. There are only 2 guidelines from the Endocrine Society based on moderate evidence. And those 2 guidelines based on moderate evidence are guidelines urging physicians to monitor for harm, monitor physiologic measures looking for harm. And at the very end, in small print of their guidelines, the Endocrine Society states these are not to be interpreted as standards of care. But again, what you hear from mainstream media, what you hear from mainstream medicine is not what the Endocrine Society puts in fine print. So what are puberty blockers? Puberty blockers are gonadotropin receptor hormone agonists. The most common one prescribed in the United States is Lupron. Lupron is an acceptable treatment for precocious puberty, puberty occurring at too young an age. It is also used among adults to treat prostate cancer in men and some gynecologic issues in women. We have to, again, get back to basics with our peers, because I have been accused of fear-mongering. I've been told, but doctor, Lupron is totally safe for precocious puberty, for prostate cancer, and endometriosis in women. So how can it be unsafe for a child with gender dysphoria? Okay, let's take a step back. Prostate cancer, endometriosis, precocious puberty. These are diseases. These are physical conditions that cause harm. Lupron is a medication that has side effects no matter when we use it. However, Lupron, in the context of those diseases, has a cost, a cost-benefit ratio that changes. What's the purpose of medicine? The proper purpose of medicine is to restore health or to restore function, to give relief. If I use Lupron in response to a disease, I'm using it because the side effects of Lupron are still there. But the benefit, Lupron is more likely to give the patient more good than harm in the context of disease. That's why I or any physician would prescribe it. A child with gender dysphoria does not have a physical disease. A child with gender dysphoria who is 8 years old may be on the cusp of puberty, normal puberty. There is no physical disease to treat. In fact, if I give Lupron to a normal, physically healthy child, I am causing an iatrogenic physical disease to that child. So again, we have to start with basic definitions to re-educate our peers. So when you give it to a normal child, you are freezing their sexual development at a time when the ovaries and the testicles are not fully mature. This is very significant because according to, the transgender pediatric medicine, you put children on this puberty blocker at age 8. So you're freezing their sexual development before they have mature ovaries, if they're girls, before mature testes in boys. If they go on, and in some cases, some doctors put them on the cross-sex hormones together with the blockers. But even if they go on the cross-sex hormones a few years later, those cross-sex hormones, the estrogen in the males and the testosterone in the females, obliterates the testes and the ovaries. You have just caused permanent sterilization of children. So the blockers at an early age combined with cross-sex hormones means chemical sterilization of children. And not just any children, as we will see, but children who have emotional distress, and the vast majority of whom do have underlying psychiatric illness, as we will see in future slides. That used to be called eugenics. Well, guess what? It still is. And we have to, again, bring our colleagues into this awareness. Other effects of the puberty blockers alone. So if we give a girl Lupron, we are essentially putting her in a menopause-like state. Again, this is any time between age 8 and 13 that it's initiated. So we're blocking the secondary sex characteristics. It has been established that the children with gender dysphoria who go on the Lupron never achieve maximal bone density. Neither the girls nor the boys. They will never achieve maximal bone density, which means they are at risk for osteoporosis at young ages. The other very critical thing that normal puberty is associated with is the organization of the brain. The neurologic organization of the brain is guided by normal sex hormones. We have no idea what we are doing to these young children's brains when we put them on puberty blockers and then also add cross-sex hormones. Are we the concern, there is a valid concern for decreased IQ and memory loss. For this reason, we know in adult medicine that Lupron is absolutely associated with memory loss and cognitive impairment in the men who are treated for prostate cancer and in the women treated for gynecologic conditions. So what are we doing to the brains of our young children with gender dysphoria if we put them on these blockers? Critical to help our colleagues understand that even temporary Lupron use, so even temporary blocker use, will cause damage that's not reversible. The normal bone density, we know that is always lost. Normal psychosocial milestones are lost. Why? Because let's say a child is on blockers for 2 years and says by some miracle, I realize I am my biological sex and I want to stop the blockers. We know that's rare based on studies, but rarely it could happen. That child, we don't have time machines. We cannot give that boy or girl, we can't bring them back to point zero and allow them to have 2 years of normal pubertal growth. They've lost 2 years of normal puberty. That's true harm. That is objective harm right there. We can't give them that normal developmental time back. It's been stolen from them. We are often told, and we hear, and we'll see studies that claim puberty blockers decrease suicide risk. Don't believe them. This particular study that came out in February of 2020, Jack Turbin is, he is an openly homosexual male adolescent psychiatrist, very devoted to transgender ideology. And this particular study of his, which he published, claiming it proved that blockers prevent suicide, his own Table 3 data disproved his conclusion. First of all, the studies are terrible. They're terrible quality, but even being of poor quality, when you look at their data, they sometimes even lie about their own data. So Table 3 of his study showed that gender distressed youth on puberty blockers had double the rates of serious suicide attempts, resulting in hospitalization as compared to the control group. So if you were on blockers, 45.5% of his population ended up having a serious suicide attempt requiring hospitalization versus only 22% of the controls. This particular statistic from his study is very believable given what we know about Lupron. If you look at the package insert, it warns that Lupron causes emotional instability, and it tells physicians to monitor your patients for the development of new psychiatric illness or worsening of psychiatric symptoms during treatment. We also have, there was also evidence for the emotional destabilization found in the Tavistock Gender Clinic of the UK. Dr. Michael Biggs, back in 2019, who was one of the whistleblowers for the Tavistock Clinic, discovered a report on the population of children there at the clinic that demonstrated children reported greater self-harm on blockers and that the girls exhibited greater body dissatisfaction when they were on puberty blockers and more behavioral and emotional problems. But it was buried. Fortunately, through a lawsuit, on my cover slide, there was a young woman who was pictured first as a little girl, then as appearing as a male, and then finally back to her true feminine self. Kira Bell, together with some whistleblowers at the Tavistock Clinic, sued the clinic, and thanks to their courage, brought the truth about this protocol out into the open. And now in the UK, the Tavistock Clinic was shut down, and children may only be given puberty blockers or cross-sex hormones in the context of an actual experiment. But we'll have more on that near the last slide. The final comment that I want to make about suicide is that rational and compassionate medicine is not driven by the threat of suicide. In any other context, as a physician, when we have a patient come to us saying that they want to kill themselves, we don't turn the prescription pad over to them. we recognize suicide as the threat of suicide as a cry for help, as the sign of there is something wrong, there are underlying circumstances, underlying psychopathology, trauma that needs treatment. We recognize further, if we're dealing with a child, that the child is not cognitively mature, that the child does not have life experience, and that when a child is suicidal, their capacity for right judgment is even further removed. So it makes no sense to when we have a child who says, I'm trans and I need puberty blockers and cross-sex hormones, give them to me or I'm going to kill myself. That's emotional blackmail. And a compassionate, rational physician would not simply turn the prescription pad over to the child. More importantly, over 90% of all suicide victims have a diagnosed mental disorder that can be treated. Children with gender dysphoria, there's no evidence they're any different. And as a matter of fact, there are many studies to demonstrate that severe psychopathology and adverse traumas, especially early in childhood, are there that need to be addressed. And moreover, more importantly, there are even 16 case series in the psychiatric literature to demonstrate that counseling has been successful in helping both teenagers and even adults embrace their bodies in the context of gender dysphoria. Is suicide inevitable without social and medical affirmation of transgenderism? Absolutely not. And we don't have to look any further than the Manual of Sexuality and Psychology put out by the American Psychological Association, or the DSM-5 put out by the American Psychiatric Association. Prior to transgender rights, the whole push, political push, over 75% of gender dysphoric children would resolve by adulthood. That's by the, and that can be found in the Red Handbook on Sexuality and Psychology. In the DSM-5 on page 451, you can calculate that among girls with gender dysphoria, as many as 88% of girls would come to accept that, yes, I am a woman by young adulthood. And as many as 98% of boys with gender dysphoria would come to accept that, yes, I am a man by young adulthood. Dr. James Cantor, again from Toronto, in 2016, pulled 11 studies looking at persistence and desistance in childhood gender dysphoria, found that as many as 90%. So the vast majority of children, if they are not indoctrinated and if they are not medicated, but instead accompanied through counseling, through puberty, the vast majority will come to embrace reality. But that is not what is happening, particularly in the United States today. Here, sadly, children come out as so-called trans or non-binary, and they are put on the puberty blocker, wrong sex hormone train. And here is what we are setting them up for. Both males who are put on estrogen, females on testosterone, we are essentially putting them, besides making them lifelong patients, we're putting them at risk for serious disease, heart attacks, strokes, high blood pressure, breast cancer, in both sexes. What we are seeing with the women, particularly the young women who start down this pathway as teenagers, many of them by their mid-20s are coming to realize that they are no better psychologically and realize, I've always been female. We can't change sex, and they detransition or they desist. What we find is even after they're off the testosterone, the hirsutism, the 5 o'clock shadow remains. They have to shave every day. Their Adam's apple is permanently enlarged, and their voices are permanently lower. And as far as their fertility, again, if they were on blockers around age 8 and put on the cross-sex hormones, then they're also infertile. My colleague, Dr. Michael Laidlaw, is an endocrinologist who is very outspoken on protecting children from this atrocity. And a picture is worth 1,000 words. In this picture, he is demonstrating or illustrating the normal amount of testosterone a female should have here in blue. Polycystic ovary syndrome is a common illness among young women that increases the testosterone in their bodies to this much. If a woman has an endocrine tumor, that's what this red line is illustrating. A female to male transitioning patient is put on levels of testosterone, as he points out above, or as it says up above, 10 to 40 times above normal female levels. In other words, we're giving them an amount of testosterone that is produced by an endocrine tumor. That is crazy. Cannot be good for women, and it's not. Here are just a listing of some of the different surgeries being performed on minors and adults in America. For girls, some of them are undergoing double mastectomies at age 13. The activist pediatricians who justify this have come up again. Remember, you pervert the language first. Joanna Olson Kennedy, radical transgender activist pediatrician in the United States, came up with the term male chest dysphoria. Male chest dysphoria refers to girls who are distressed that they have normal breasts. They are not male. They do not have chest dysphoria. Okay, but again, you pervert the language to justify your perverted treatment. Excuse me. We have also had girls as young as 16 undergoing hysterectomies. We have had boys undergoing so-called girls age 17 undergoing phalloplasty, the creation of a facsimile of a penis. It's non-functional, of course. Among males, age 17 seems to be still under age 18, where they can undergo castration, penectomy, and I don't even like the word neovagina. Again, it's fake language, right? No one can create a true vagina in a male. It's a genital wound that must be regularly dilated. And what I really want to point out here is that the overall message, what we are dealing with here is not the narrative of a minority population of people. No, we are dealing with boys and girls who are emotionally troubled, and we are sterilizing them. We're sterilizing them chemically with puberty blockers combined with the cross-sex hormones, or we're outright sterilizing them through hysterectomies and surgical castration. And this is what has been swept under the rug. In addition, if we look at long-term studies of adults, this is out of Sweden. It is an open access article, long-term follow-up of transsexual persons undergoing sex reassignment surgery, 2011. And this image here is all-cause mortality. The solid gray line at the top is all-cause mortality for healthy control women. The black line at the top here are healthy control men. The dashed gray line here is the increased mortality of women who believe they are trans and undergo hormones and surgery. The all-cause mortality for men who undergo hormones and surgery. There is a threefold increase in all-cause mortality. And this was seen, the drop-off began at, the significant drop-off began at 10 years post-op and peaked at the end of the survey. The study was 30 years. So we are not helping children, or adults for that matter, through hormones and surgery. How about the claim in the narrative that the children are not mentally ill? As I stated earlier, there are many, many studies that refute this. There is significant mental illness among adults and children currently with gender dysphoria or transgender identification. I note this one study from 2018, Becerra Kulqui. It was a Kaiser Permanente chart review in the United States. Thousands of patients were looked at, thousands of charts rather were looked at. And this study was unique in that it established that the psychopathology came first, before any symptoms of gender dysphoria, before any identification as trans. And the pathology they found, everything from depression, anxiety, neurologic difference like autism, ADHD, but even significant hospitalizations, self-harm, and suicidal ideation. You know, as much as the suicidal ideation was as much as 54 times higher among children who eventually came out as trans. All of this was present before, as I said, before any sign of gender dysphoria, before any sign of transgender identification. So their suffering precipitates the gender dysphoria and the transgender identification. Their suffering is most certainly not caused by us who say they need counseling, they need psychotherapy, they may also need family therapy, they may also need psychiatric medications. We are telling the truth. No truth, no love. It is not loving to affirm them in their false belief. It is not loving, it's not healing. This is a picture of Dr. Paul McHugh, recognized in the United States as probably the most important psychiatrist in the last 50 years. In 1979, he was responsible for shutting down the Johns Hopkins adult transgender clinic because in 1979, he published a study to demonstrate that the psychopathology among adults who underwent hormones and surgery was not treated, did not get better with hormones and surgery. So he was quite horrified in around 2013 when he saw this being pushed on children, and he became a vocal critic. We became friends. And he was quick to point out, look, gender identity disorder is very similar to body integrity identity disorder. In this case, we have fully healthy adults who long to be paralyzed or amputees. They claim, adults with body integrity identity disorder claim that they are actually amputees or actually paralytics trapped in abled bodies. Not very different from a man who says he's actually a woman trapped in the wrong body. So Dr. McHugh would always encourage his medical students, his residents, to approach gender identity disorder in the same fashion that they would approach body integrity identity disorder or body dysmorphia and or anorexia. You treat the underlying conditions. You do not affirm the false belief. This slide is showing that, again, it starts on the x-axis around 2009, and it runs about a 10-year span on the x-axis, looking at, these were referrals to the Tavistock Clinic in the UK. In the early 2000s, referrals for boys and girls, the girls are the reddish pink, were about even in the early 2000s. Then eventually we had this sudden divergence, a sharp increase in girls. The girls being referred over that 10-year period increased by 4,000%. The boys increased by 2,000%. This was unusual because in the 1970s, 80s, referrals were very rare, but you would tend to see more boys being referred than girls. Now it is reversed. And largely, we believe this is because it's become so internet-fueled, media-fueled, internet, social media-fueled. And just as body dysmorphia, anorexia is more common among girls than boys, this gender dysphoria is more common among girls than boys. We know that indoctrination is playing a significant role. This slide was put together, again, it shows correlation. It was put together by a radical feminist friend of mine. There are radical feminists who are on our side, dramatically against the chemical sterilization of children. And what she has noted in this slide is that this light blue line, the light blue grayish line with peaks, those are girls who present for gender transition. The darker line across the x-axis, those are the boys. The blue line on the vertical axis is when we had, that's 2004, which was the advent of Facebook. The green line is the advent of Tumblr. The red line is the advent of Instagram. You can see that there is a peak, an increasing peak with the advent of each social media launch. In addition, our children are being indoctrinated to believe that transgender belief is normal in their schools. Here we have, and I believe in Europe also, drag queen story hours at public libraries. The young adult and even preschool books promote this, as of course does television. So again, to bring us back to the reality, psychosocial factors are the predominant cause of transgender belief. Like any behavior or psychological illness, our genes play a role, vulnerability, combined with our environmental experiences and our free will agency. Social reinforcement, social contagion is coming through families that are being told, do this if you don't want your child to die. I don't blame parents, because parents are being emotionally blackmailed. They're being lied to and blackmailed. But schools, gay clubs, LGBT clubs at school, the internet, all forms of media. In some cases, parental psychopathology and family dynamics does play a role. Child sexual abuse, physical abuse, verbal abuse can play a role. Inborn neurologic difference, such as autism, actually does play a role. Among children with autism, gender dysphoria is 7 times more common. And free will choices, such as choosing to get the addiction, is not a choice, but just starting to pursue particular social media platforms before you get addicted, there is some choice there. Am I going to look, oh, I accidentally got exposed to porn. Am I going to pursue it to the point that I become addicted? So there's some choice there. Is there good news? Yes, there is. There is some good news. The good news is that in Europe, there have been systematic reviews of the scientific literature starting in the United Kingdom, in part, and I really do believe we owe Kira Bell a tremendous amount of thanks, because she brought the lawsuit against Tavistock. So United Kingdom, Sweden, Finland, Norway, and Denmark have each undertaken their own systematic reviews of the scientific literature and concluded that there are no good long-term studies to establish efficacy or safety of these transition protocols in children. So within the countries of the United Kingdom and the others, they have said that the first order of approach is psychological. Evaluate the child, evaluate the family, and move forward that way. No puberty blockers, no cross-sex hormones, no surgeries. They do allow for, in extreme circumstances, they will allow children to go on the medical pathway only under strict, a true experimental protocol. Now, my colleagues here in the States are happy to see that, and we very much want the same thing to happen in the United States, and that's what we're pushing for. However, we can't let that be our endpoint. Why? I have colleagues here who are actually saying, hey, we need randomized clinical trials, RCTs, randomized clinical trials. Now, again, let's take a step back. I have a big problem with that. I say, no, we don't need any more trials. We know what we're doing. We are sterilizing children. How dare you say to me, how can a randomized clinical trial of puberty blockers, cross-sex hormones be ethical? How can I look at a group of gender dysphoric children and say, okay, we're going to randomly assign half of this group to be chemically sterilized and the other half not, and then follow them out 30 years and see what happens? How can that be ethical? And this is just my last slide here. Here in the States, we have an organization called Equipped to Love, and these are Christians who left the LGBT lifestyle, and they're having quite an impact across our country. And it just says it all. The one true faith plus science, one true faith plus proper counseling, psychotherapy, and or medicine can bring the greatest healing. And I hope I didn't go over by too much in my time. But if there is time, I can try to take some questions.
Dr. Cretella, I think we're a bit short of time, but allow me to say that is one of the most profound lectures or talks that Doctors for Life has ever had since 1991.
Oh my gosh.
Yes. This is of extreme value for us. Doctors for Life is asked to testify in many court cases We have been asked to testify, and this is the kind of information we need for that. I must say our Zulu translator, I take my hat off for our Zulu translator at the back, because he translated to a group of lay people at the back. But this is of
Oh
such
my goodness.
importance that I think we must go out of our way to get this talk translated into a language that is easier understandable to the lay people, and we are planning to do that. But for our medical members and people who are interested in the activity of Doctors for Life, this was perfect. And thank you so much for this talk. And I hope you don't mind if we contact you in future for advice and to get guidance in how to carry on with this matter, because we are faced with the same challenges here in South Africa.